we've been a little bit too optimistic for AI in healthcare in the past few years. And so sometimes optimism become bullshit. And then, so that's why I actually want to come back a little bit and talk about its successes and also failures. So this is the knowledge of the country. And so I'm a biomedical informatics professor first, and then I became a dermatologist later, a little later, actually. And I'm also elected fellow of the American College of Medical Informatics and the International Academy of Health Sciences Informatics. And amazingly, I'm also a fellow of the Australian College of Health Informatics since many, many years ago. I did not contribute much, though. I'm an editor-in-chief for the journal under BMJ, BMJ Health and Care Informatics. I'm the current president of the International Association for Medical Informatics. I also humbly call myself a serial entrepreneur because I had 2.5 startups in the past 5 years. 0.5 means one's still in incubation and cooking. The other two just got round A funding, so it's going to survive for another few years. So if you have, I'll mention a little bit about the startup, but this is mostly not about it. So you've all been doing AI, data science. May I see a show of hands if you think yourself as a data scientist? Can you raise your hand? All right, okay. And a clinician? All right, great. Who are the others? Okay, a medical informatician? Okay, only 2 of them, 3, okay, all right. But I believe you've all heard about AI or used AI or create something in AI. But the AI we're talking about are mostly machine learning AI, right? Since the day, myself and Wendy, since we're, when we're doing AI was still a dirty word, right? So I talked to my friends back in 1993. I talked to my friends who was doing PhD in UC Berkeley, and he asked me what because I graduated from medical school, and he said, what were you doing in kind of Utah? And I said, oh, we're doing AI in medicine. He's, what, AI? He cannot believe I say AI. And I actually asked the faculty members, and they're also, oh, nobody's doing AI. It's bad to do AI. We're doing medical decision support. We're doing kind of expert system, knowledge base, knowledge representation and stuff like that, but nobody's really doing AI. But actually back then, AI means a much different model. It's mostly knowledge engineering. But now when we talk about AI, it's mostly about machine learning. That's why data, that's so data driven. And all of you already know, if we don't have big data, we don't have the current machine learning AI. And 2045, I hope we all see that. According to several books, right? In 2045, we reach the age of superintelligence. And what does that even mean? That means you can buy a set of computer, for $1,000 or more, and that computer would have almost the same amount of connections like a human brain, okay? And it would work like a human brain, except that it doesn't sleep. And as long as it's plugged in, it will work. So imagine Amazon got 100 million human brain working for them. Google got 200 million human brain working for them 24 hours. And what would that bring, to the future? I don't know. I have no idea because I don't have 2 million human brains, only 1, and it's getting older. So, so IMIA is the International Medical Informatics Association, and Phil has been with IMIA for a long time too. It's established in 1967. It's a formal NGO under the WHO based on Geneva, and it's the largest international medical informatics organization with more than 60 member countries. I was just taking over the presidency over the Dr. Sabine Koch from Sweden. And last year, well, actually in 2020, we wrote a letter to WHO about how to use informatics against pandemic. And there are 4 major points. One is we need to be preemptive. Looking back to, this is like almost 2 years ago. Well, it's actually more than 2 years ago. The letter was in the April of 2020. Now we're in April of 2022, right? Well, this 2 years really flew by. So we recommend that we need to use AI to be preemptive, and telemedicine, of course. And it's been reality. It's not a vision anymore. And we need to share data to create big data in order to drive the machine learning AI or data-driven AI, and also transparency. I think we've gone a long way, on the 4 paths. So with that, the future I see about healthcare and AI going together, that will be three different things that I would like to talk about. The first thing is smart. We need to be smart in every way. We need to do health from home. Actually, we already work from home, right? Now we need health from home, and early and earlier for everyone. I'll explain that one by one. So smart in every way means we need to use AI in every segment, every processes in a hospital and healthcare organization, not just in the radiology department, which you've seen a lot, right? We need to use AI in ER, outpatient clinic, inpatient clinic, ICU, operating room, and of course, including radiology. So all the places, and also all the data sources. We use AI on images, of course, but we also have gone a long way on text, right? And then biosignal, we've been doing that for forever using AI. And then codes. I'm going to tell you some of the progress that we made on using AI on massive codes. So no matter what is the data sources, there are always a lot of ways that you can use AI to enhance them. And also stakeholders. It's not just, we should not just create AI for care providers, which is happening already. We need to also create AI for patients, because if we want to stop diseases before it becomes diseases, we need to give the tool to the patient, right? They're the front line. Of course, they're the one who suffer from the disease. If we all give the tool just to the providers, it's always a little late, right? And then administrators and insurers, of course. Personally, I'll be interested in, well, I have been interested in quality and patient safety, and how AI can help that. Actually, before I came here, I was in Brigham and Women's Hospital with Dr. David Bates for 6 months last year. And also, if anything, we're not trying to replace physicians, we're trying to replace their burnout, right? Before we can replace physicians or nurses or other medical professionals, we should reduce their burnout first. So these are the, this is a very busy slide. These are the medical AI that's been approved by the US FDA in the past 3 years. There are like 80 of them. They're not a lot. But if you look at them, half of them for this primary, they look at that as a primary specialty and a secondary specialty. So primary specialty is mostly radiology. As you can see, most of the products, passing through US FDA is kind of like a very, very good test to see if this really is a, has a product potential. It doesn't mean that you can sell it, but it means that it can work in a clinical environment and you spend enough time and money on it. So radiology is about 50%. And then the second largest will be in cardiology, as you might imagine, because of all this EEG, ECG and wearable devices. And also the amount of images generated by the department. And the rest are like neurology, pathology a little bit, ophthalmology, and things like that. But if we look at the secondary medical specialty, which means if you use radiology image for cancer, diagnosis, then the second specialty will be oncology, right? So as you can see, number one secondary medical specialty is oncology, which is about 30% of all the FDA-approved AI in healthcare. And the second one will be emergency medicine and also neurology. Some used in pulmonology, some in cardiology, of course, intensive care, and endocrinology. And also, where do you find these FDA products? Of course, they're marketed individually by their companies, but now we're seeing more available in the form of like the App Store, right? So GE has its own software shop online, and these, of course, mostly for images. And Epic, which is the largest healthcare information system provider in the US, has what they call the App Orchard, right? App Orchard, like fruits. So, and there are already like 547 applications in the App Orchard of Epic. One of them happens to be from one of my startup. It's called MedGuard. So we're on the App Orchard, and this product, actually, this software is an AI for detecting medication errors. So as long as you provide, I mean, this is a plugin for Epic, apparently. So whenever you're looking at the medication list, it will actually flag out. It will help you flag the medication that's unexplainable. So we call it, it's probably an error. Unexplainable means we cannot find any evidence from diagnosis, problem list, lab data, and among other medical record data that the patient should be having this drug. Okay, so that's called, we call it unexplainable drugs or inappropriate medication. So that's a system work in the background that whenever you're reviewing patient's medication, it will flag the medication that cannot be explained. That is the RX Prime. So this is one of the startup that I was talking about. We call it ESOP, or AI to enhance medication safety. So majorly there are two things. One is RX Prime. It's about medication errors. It's focusing on the 1.5 billion medication errors around the world a year. The other is called DX Prime. It's about charting error and omissions of diagnosis. As some of you may know, one of the things that we need, that's missing a lot in our medical record is diagnosis and problem list. I'm not sure you know about that, but that's the case. Well, when I was working with David Bates back in Brigham and Women's Hospital, they estimated 40% of the diagnoses were missing from Harvard Medical School's medical records. So, and that's kind of one of the best hospitals. So that omission is not only going to deteriorate or lower the quality of the medical record, it also would generate denials from the insurance company. Because you don't, for example, if you don't have diabetes and you give patient insulin, well, of course you get a denial from the insurance company, right? But this is, of course, an oversimplified case. Usually it's much more complicated than this. In the US, every year there's a 600 billion denial from health insurance bills, right? It's crazy because the total expenditure is like $3.5 trillion. Last time I was talking about it, it's only 2 or 3. Now it's 3.5 or 4 trillion dollars, right? It's like $1 trillion is like dollars. They're growing so fast. Okay, so the second point I was talking about is health from home. Part of me is for this a little gross because that's from my patch. It's a continuous glucose monitoring device from Abbott called Freestyle Libre. I was testing it because my father has diabetes and I was trying to put one on him. And before I did that, I tried it on myself. And it doesn't hurt at all. So it's a good news. There's a microneedle here. and there's a applicator, so it's quite conveniently applied. Well, I don't have sponsorship from Abbott, anyway, but I kind of like this product. You put it on your upper arm for like 2 weeks, and every 5 minutes it will give you a update of your glucose level. So you actually know, what did you eat from the breakfast or lunch or dinner that would elevate your glucose quite fast. So sometimes I thought I ate almost the same thing for dinner, and one dinner I got a very fast glucose raise because I drank all the soup that I got from a store, and the soup tastes nice, but now after when I look at the numbers, I know they put a lot of sugar in the soup. Wow. So anyway, so now so it's a very different feeling, and you don't have to prick your finger, right? So it's a very different feeling to know minute by minute what your sugar will be. And when you sleep, you actually, when you dream, your sugar get high a little bit, and then it's mostly low, right, when you're sleeping, but when you dream. So you can almost see what you're dreaming about. Not really what you're dreaming about, but how exciting your dream will be, just looking at the blood sugar. So it's not just tele-screening, tele-consultation, tele-intervention. Of course, we've seen a lot of tele-consultation. Like I think in Australia, Babylon is doing well, is it? Right. So Babylon and Teladoc, although their stock are not doing very well now, but anyway, and Netflix just dropped like 50%, right? So so tele everything, but the stock is not doing very well. The reason being there are so many competitions, right? So because now everyone is seeing the trend and everyone is investing it, just like Netflix. So it's no more just Netflix. It's Disney Plus, it's HBO Max, and this and that, right? And Apple TV and stuff like that. So, but again, the hype become a norm. That means it's part of life now, right? Tele everything, tele intervention, and also tele intervention as well. We are seeing more and more digitally prescribable intervention, right? So instead of prescribing, this white tablet 3 times a day, now you can prescribe this app 3 times a day or 3 times a week. You use the app for 10 minutes, 3 times a day, right? And that will help you sleep, will help you walk, and things like that. And so my third point is it will get early and earlier for everyone with AI. So we've seen so many papers about disease predictions, disease screenings. Of course, after COVID-19, I mean, it looks like every other company is providing a COVID screening kind of online, although it's not very accurate, but they're trying. And disease monitoring, progression, and especially microprogression. For example, pressure sore, right, on the back of, mostly on the back of the patient, a bedridden patient. If you look at the bed sore or the pressure injury, pressure sore, if you look at it day by day, even a very senior nurse or a kind of a bed sore specialist, it's very hard for them to distinguish the difference day by day. So usually they review it every week. But again, a week is a long time for the patient, right? So if we use one of our projects, use AI to look at the microprogression of pressure injury to guide the care for the patient. So we don't have to wait a week to know that we did not do the right job for caring for the vessel. And of course, mortality prediction and even disability prediction, meaning if you know that this group of patients is going to suffer from a high risk of falling, and then the fall would lead to fracture leads to a great disability, right? So you could target that group of people and prevent them from suffering from that disability. So of course, now I have to tell you a Chinese saying, which was written on a book called Canon of Medicine, 1500 BC, arguably the earliest book on medicine. And it says, the best doctor is focused to keep people healthy. The average doctor works on the sub-healthy people, and among them, doctors treat only the ill, which, you know, I am, and most doctors were trained to do that. You know, so anyway, so, but I hope that AI could help us, you know, elevate a little bit from mundane to average, and eventually, you know, even better, so we can keep people healthy and not just treating the ill, which is too painful and too much money, and, you know, quality of life are not good. So we usually says minor disease, you go to the clinic, well, at least in my country, because in Taiwan, you could just go anywhere. You could go to the largest hospital and see your specialist almost the same day. You know, you can make an appointment in the morning and you get it in the afternoon. You can see the specialist in the afternoon. So I mean, we're too free. That's another problem. So the government would tell people, although you can do whatever you want, but minor disease, go to the clinic, please. And major disease, go to the hospital. But the consumer, the citizen, the people would say, how do I know it's a minor or a major disease, right? And what if I do not go to the hospital for a minor disease and it become a major disease, you know? So I might as well just go to the hospitals. That's why our hospitals were all very crowded, and the clinic were like not so crowded. And we're crazy about the efficiency of hospitals. So our hospitals are very efficient. You could get an MRI in 3 days. You could get a CT CAT scan in 2 days, an endoscopy in 3 days. So they're crazily efficient. And if you go see a doctor today, you get a medicine before you leave the hospital. You don't even have to go to a pharmacy to get your prescription filled. So our hospital are crazily efficient, and there's no waiting list. If you need even elective surgery, not an emergency, elective surgery, you can pretty much get it done next week. For emergency, of course, you get it done today or tomorrow. So yeah, so that's the problem. So that's why our hospital were full of people. I was joking, it's the train station and then the hospital, you know, if you want to see people. And it happens that going to the hospital is one of the most dangerous things that you can do as an average citizen. I think the number one most dangerous thing is rock climbing without a rope, untethered rock climbing. That's kind of number one. And number two is going to the hospital. And people going to the hospital like they're, you know, that's a supermarket. And we do have some supermarket in the hospital, which is crazy. And restaurants in the hospital, you know, not restaurant, food court in the hospital. Have you seen food court in the hospital? Maybe not. Maybe you have coffee shop in the hospital, right? We do have a full-blown food court in the hospital, which you can, you know, all kinds of dishes. Anyway, so minor illness and major illness. But the problem is sub-healthy people, where do you go? Well, there's no doctor that you can see. And especially when you're healthy or you're on the edge of healthy, where do you go? I mean, there's no doctor that can treat healthy people or maintain healthy people. That's not what doctors do. Doctors treat diseases, right? So that's why I put precision prevention here. Health checkup is a big business in Taiwan and also now in China. Health checkup is it's almost like a $20-30 billion business in Taiwan. So we use, some hospital use PET scan, positron emission tomography, use PET scan as a health checkup tool. So some people actually go get PET every couple of years, you know, to screen for the cancer, stuff like that. It's probably not very smart, but anyway, and it's quite expensive too. And for sub-healthy people, I think we should have some smart consultation, which could be AI as the first line, and then probably some experienced nurses and then doctors. Of course, it could be fee-based or free. It depends on the country. So, so we coined a term called earlier medicine. If you would really want to know the definition, it's in the paper. which we wrote with Dr. Leo Anthony Sally from MIT. The short definition is the temporal predictive and proactive approach to individualized health enabled by innovative AI modeling plus longitudinal personal health big data. Okay, it's quite a mouthful. But actually it's about individual big data or personal big data across the timeline. So we want to collect, we actually in Taiwan, we've already collected a time-based personal data since 1995. Yeah. So everybody who was born after 1995, almost all their temporal or their time-based medical records are all somewhere in the government's database. and they can access them. So if you want, you can open it. But only you and yourself can access your own medical record. Yeah, I argue that once we have this big data for each person over the time period, then we're able to do early medicine, meaning we can be a little earlier every step of the way. For example, a lot of people suffer from breast cancer, or even worse, lung cancer. And 50% of the patients who were first diagnosed as having lung cancer were in stage 3 or stage 4, which is too bad, right? And it's very high mortality cancer. How about if 80% or 90% of the lung cancer first diagnosed are stage 1 or stage 0, right? Then we don't have to spend a lot of money and all the drugs and the surgery. This is quite personal for me because my mother suffered from lung cancer. She passed away several years ago. So when she was first diagnosed, she was stage 2B, which is kind of 3. And then she fought the cancer bravely for 12 years, and then she passed away. But it's a quite painful process. So if everybody who got cancer, if somebody has to get cancer, you want to get cancer stage 0 or stage 1, right? Because in stage 0, stage 1 is mostly curable. But after that, it will be a very long and painful and expensive process. So if we can do everything a little earlier, okay, not just preventive care, even acute care, if we can do things a little earlier. For example, insulin. When is the optimal time to give insulin to a diabetic patient? Most patients will still resist. So they want to be on metformin, and all these oral drugs. But once you prescribe insulin, they're like, oh, that's the end of my life, or I'm in the end stage of diabetes. But which is probably not true. So of course, in some cases you want to be early in using insulin, right? But when, who, right? And we don't know that. If we just use average, meaning that's how the current medicine practice. We use average, right? So most people, when their HbA1c is this high, when their sugar is this high, when their complications are this many, then we use insulin, right? But I'm not most people. I'm just one person, right? So I'm different from average. I always joke about average. We used to have a mayor. We still have a mayor, the biggest city called Taipei, and the mayor was a doctor. He's an intensivist, and every time we get a agreement, questionnaire for a group of people about this mayor, 50% of them will say, I totally like this mayor. I'll give him 5. The other 50% totally dislike or hate the mayor, and they'll give him 1. But the average score for the good would be 3. No opinion, right? So that's what you get from average. And that's how we practice medicine here. Right? Not just here, the whole world. We practice medicine on average, but when you're averaging a group of people with 5 and a group of people with 1, and you administer 3, 2 of them. But the 50% of them need 5. The other 50% need 1. But none of them get what they want. what they need. They just get 3 because it's the average. That's how we practice medicine, and that's too bad. And the reason that's how we practice medicine is because there's just too much data on individual, or not enough data sometimes. And sometimes we have too much, sometimes we don't have enough, or some aspect. So we practice on average. We give drugs to people, most of them don't need that, or they don't. That's not the right concentration. That's not the right amount for people, right? Some need more, some need less, but we'll just give them average. So that's too bad. I was kidding about, well, it's not actually kidding. If you check your liver function, there's something called GOT and GPT, or ALP and AST, right? So these are the 2 enzymes that you check for liver function. And that enzyme, usually the borderline, the critical value is 40, usually it's 40. So if you're 41, you have a bad liver. If you're 39, you're totally healthy. And that's the same for a 10-year girl and a 90-year-old man. How can it be the same? And how can it be right? I mean, you don't need a PhD to know something's wrong with this picture, right? So we should stop. Well, we should start to practice more individualized, using the help of these data. So anyway, so much being said. I still want to show you something that's from my other startup. Sorry about this. Anyway, of course I have stake in the company, but they're not public, so you cannot invest in them. Anyway, so one of the other startup is called Derm AI, because I'm a dermatologist. So my fellow dermatologist asked me, "You're a dermatologist and you know about AI. So what's your contribution in dermatology?" And I said, "Nothing." I mean, through AI is nothing. So I have to do something about it. So this is my take on the something, right? So I say, okay, mole, right? Everybody has a mole. Everybody has a mole on your skin, right? If you can find one person without a mole on the skin, I'll give you $10. So everyone has a mole. So mole is me. So we create an app called MoMe. So it's easy. If you're interested, you can just scan a QR code. So you just answer 5 questions. Very in 1 minute, you can scan. You can do 5 questions, and then you can take a photo of your mole. Melanocytic mole, I mean pigmented mole, mostly. It works mostly on pigmented moles. So Tommy asked me, what's wrong with this mole on his paw when he was like much younger? And I said, it doesn't look wrong. And he said, but I Google it, right? Acrolentiginous lesions, meaning pigmented moles on palms and soles, are the most prevalent form of melanocytic malignancy in Asia. And I said, okay, you're right, right? But this is not malignancy. And then, so let's do AI and check on it. So AI take a look and say lower risk. Okay, so now he's happy. So apparently he's still there. So, so the AI was right so far. And this is another 19-year-old boy. Oh, a very tall boy, and his mother brought him to my clinic and said, "Oh, we use your MoMe, and this MoMe says higher risk." And so I take a look at it. It's a pigmented mole on the back of the. Oh, it's not very clear here. On the back of this boy, and so we did a biopsy, and it's dysplastic nevus, meaning it's pre-malignancy. It hasn't changed into malignant, but it's gonna change. So we removed it, and the mother was very happy. So the mother brought all her 3 boys for the whole skin checkup. All right, and she was happy. So this is a 20-year-old girl, well, not girl, a lady. So she came into our clinic and said, your MoMe says I'm high risk. So we did a biopsy, and it's melanoma in situ, means it's stage 0 of malignant melanoma. And she was very happy, and we were happy. You know, we want to stop this. early. We don't want things to get worse like this. This is an 80-year-old female. And of course, you don't need the AI to know something's wrong with this thumb, right? It doesn't look right at all. But this grandmother, she said, "Oh, I'm old enough, so whatever happens, happens." And she refused to see any help. But again, if you use AI on her, and it's stage 4 malignant melanoma already. So, so this is the news from our local news, and now we have helped about 100,000 people, this app, since its creation. Although we earn very little, we earn very little money for this help, but it's happy that we can help. We're happy that it can help. And we also publish papers about the performance of this MOMI. It's the red line, and the green line are, the green triangles are actually primary practice physicians. And the performance of the app is generally better than the primary physicians. And it's in BJD if you're interested. It's in British Journal of Dermatology. And yeah, and then I'll give you some other examples of predictive AI. So we did a lot of predictive AI. This is to predict major adverse cardiac events. You know, pardon me for the specialty thing, because I have a lot of different, I have a student in different specialties. So I'm a cardiologist and neurologist, and I'm a dermatologist. So we kind of do study all over specialties. So this is a kind of a cardiologist thing. And this is prediction of resistance for target therapy drugs on lung cancer. Okay, so some people, like my mother, when she started using target therapy, the first target therapy drugs last only 2 years before it became resistant. And then we have to switch to second generation and third generation until we end up with the 6th generation target therapy. You know, and but again, some people just don't develop resistance. Some very fast. So so we used some predictive mechanism to predict when people would get resistant to the drugs. And yeah, the paper down here is to predict dementia with early palliative care interventions. So we know before the dementia people is going to get worse, and we'll before they get worse, and we intervene earlier with this palliative care. So that's what I said. Earlier medicine is not just about prevention of disease; it's also about early intervention of chronic disease, chronic conditions, or acute conditions. But of course, we want to prevent disease too. Okay, so a series of study done in my lab is about using the past 3 years data to predict whatever is going to happen in the next 12 months. Okay, and the way we look at the temporal data, we call it temporal phenomic map, is that we formulate all the variables. These are the variables, drugs, diagnosis. We use about 2,000, 3,000 variables, and we formulate them in a time series, and we turn them into like a 2-dimensional map. Okay, and then now we can use all the advanced AI algorithms on images, right? CNN and RNN and a lot of things. So, and we found out it's quite accurate. You know, so we turn each patient into a map. Okay, so after a while, if we say, oh, these are the patient with lung cancer, and these are the patient without lung cancer, then when we give the engine, the AI engine has hundreds of thousands of images, they eventually know who's gonna get lung cancer, who's not. So this one is published in JAMA Dermatology, and it's probably the first paper in the world that do not use image to predict skin cancer, right, at all. So I want to publish something that don't use image, because everybody's doing image. That's crazy, right? I want to do a non-imaging information, but we use sequential medical records. And of course, we secretly turn the medical record into an image. But that's not a visual, like human image. It's an image that nobody can read. Yeah. So like this, right? So it's not skin image. And we were able to predict non-melanoma skin cancer to an accuracy of 89%, which is not very high, but it's quite interesting. And same algorithm for lung cancer. And then for liver cancer, hepatocellular carcinoma. So we look at all the cancers that we can predict. So if you give me 3 years of the patient's data, medical record in the past 3 years, I'm going to give you this type of accuracy in terms of predicting each cancer in the next 12 months. Okay, so liver cancer is the #1, and prostate cancer, and colorectal and breast. So we publish on lung, skin, and liver. Okay, I want to publish them all, but then some academia don't like people to repeat their algorithm too much, right? On different. I could do this on all the disease. Okay, publish 400 papers, but that's not good. That's not a good practice. So I forget about. So these are all phenotype. We're very deep into phenotype. What is phenotype? Or phenotype surrogates, phenotype proxies. What is phenotype? Everything that we got from medical record that's either tested from the lab or determined by the physicians, we call it phenotype. So we have medication, procedures, Prof diagnosis, problem list, patient profile, lab and exams. So these are all our phenotype. So if we look at the phenotype across time, and if we're lucky, we have some genotype data, we have some exposure type data, which is environmental data. And if we're even luckier and we have some microbiomic data, and then the patient, we're doing this wearable device and we have some behavior data, then we probably have all the data we need, right? So if we have whatever data we have from birth to now, we can almost predict a lot of things, right? Not necessarily everything, but a lot of things. So that's what we want to do, is to predict from now to death, between now and death, all the clinical events that could happen. So we want to do early diagnosis, early intervention, early rehabilitation, things like that, in order to reduce the cost and enhance the quality, of course. Okay, now a few minutes for failures. Let me just get to the point. So there are 3 types of failures, well, based on my slide. There are 3 types of failure. One is training data. So I'm all about machine learning AI. So if you have incomplete or biased training data, of course, you train an engine that's incomplete or biased, right? And that happens a lot, okay? And if you train the engine perfectly, but then when you start to use it, you give incomplete or biased input data, of course you get wrong result, right? Because the input is wrong. Even the engine is perfect, right? So the car is perfect, but the driver is drunk, it's drunk. So of course you hit somebody. But if the driver is perfect, but the engine is wrong, you can still hit somebody, right? So that's 2 different type of error. And then there's this data set shift problems. That's kind of a most important problem. So I've reviewed a lot of cases that's sent to our FDA to be approved for AI in healthcare. And they tell me that they've screened like 100,000 patients, okay? And then they excluded 60,000 images. And there are 40,000 images that they use for training. And I asked them, why do you exclude the 60,000 images? They said, oh, it's unclear. It's not focused. It's badly taken and things like that. So I asked him, so you train your engine with this 40,000 perfect, very nice images. And now you use that engine in the real world, which 60% of the images are imperfect. Would it work? Or would it work maybe 40% of the time? So what does that mean for healthcare? I mean, if you put an engine, and most of the time you'll say, oh, I don't read this, I don't read that. Does it really work or not, right? So that's only one example of selection bias. There are many, many ways to create selection bias, okay? You go to one hospital, and the hospital's work-friendly. And they say, oh, I'll give you, 10,000 images, right? And the hospital happens to be OBGYN in the hospital, right? The other hospital says, oh, no, we're not going to give you anything, give you 500 images, right? And that's a psychiatry hospital, right? And then you generate your AI, you train your engine with all these images from OBGYN hospital, and then you use it in a psychiatry hospital. How could it work? Of course, it doesn't work because the norm, the distribution are totally different. The norm are not the same. So selection bias, sampling bias, and of course, labeling bias, right? So you got this 10,000 images from this friendly hospital. But who's going to label it? You hire a radiology to label it? Of course not. You hire some research assistant. You tell them, okay, this is a nodule, that's a plague, this is opacity, and then they label it, right? And then you train your AI based on that type of labeling. You got a lot of labeling bias. Or you hire somebody, there are companies that they hire a lot of research assistants. Still, it's impossible that they hire 2,000 radiologists to label it, right? And not all images are radiology image. You have endoscopy image and you have stuff like that. So a lot of bias during the training data, and also a lot of bias during the input data. One thing that we were taught when we're students, and me and Wendy in Utah, is that missing data is a known, not negative, right? So we were using Watson for oncology, IBM Watson for 2 years, okay? They gave us a very good deal, kind of a 10% of the license fees or whatever. It's gone anyway. So during the 2 years, we're able to just play with Watson for oncology, whatever we want. And the problem with Watson for oncology is there are two types of input. One is it asks you questions, and then when you answer, it leads to more questions. And then there are questions after questions after questions. And it took like 30, 40 minutes to finish all the questions, which nobody has time to do that, right? If you're an oncologist, you spend 40 minutes entering data, it's crazy. So the other mode of input is just copy, paste the whole medical record as a group of text. Okay, imagine how accurate would that be? And so you copy paste the whole thing as text, like WBC 313K, that's the text, right? And then comma, and then parentheses, normal range. And it's supposed to read that, okay? If you're a doctor, you could probably make out what happens, but it's supposed to read that. And how about the things I did not copy and paste into it? Is it negative or a no, right? So they're bound to get a very biased input anyway. I'm not saying this is the only problem with Watson for oncology. It's got plenty of problems. So it's always hit and miss, right? So the way you input data can totally change its behavior, which is, kind of a diagnostic. It's not even a diagnostic decision support. It's a therapeutic decision support. It doesn't do diagnosis. You have to tell him, not him. You have to tell it what's the diagnosis, the breast cancer. It doesn't do diagnosis. It gives you therapeutic recommendations. So if you change the way you input, you get different therapeutic options. So what do you do? So missing input is very important. Okay, so the third one, data set shift problem. If you have read the paper from New England Journal of Medicine, then you can skip this part because I'm just trying to summarize from this paper. It actually summarized 3 changes that would cause the data set shift problem. One is changing technology, one's changing population setting, and changing behavior. Okay, so there are 3 changes that will cause the data set shift problems. And again, data set shift problem is a long aware problem by AI scientists. It's not a medically special problem, but this problem happens a lot in healthcare. Okay, for example, changing technology. If you use the endoscopic images, if you capture those images from like Olympus, the brand name, and you change it to some other brand name, and you use the same AI, it may not work because the hues, the contrast, it may not be the same. And especially if you switch from Cerner to Epic, okay, then the terms, the source data, they're all different. So you could get into really big trouble. Even, do you use Epic here?
Well, different hospitals.
Okay, so some use Epic. So even if you're the same system that works in 2 different hospitals, both using Epic, they can be facing different terms because Epic has a way of defining local, domestic, hospital, internal terms. And so your WBC may not be the same as my WBC, although they're all both white blood cell count, but they're different method, different condition, and a different code for that. So changing technology, changing population setting, of course. This is very famous because Epic has an AI that predicts sepsis for ICU patient, right? And so in the past 2 years, people found out that there are a lot of false positive. I mean, it's crazy that they have turned it off, the sepsis prediction. And the reason, the AI did not change, but the reason they investigated, and the reason being patients in the ICU are totally different now. They're all mostly COVID-19 patients, right? So the ICU did not used to entertain, well, that's a bad term, but they do not used to accept so many patients with respiratory function problem. So the population changes, and so the AI did not work. So they have to turn it off. And so these are like the black swan event, right? Have you heard about? Of course, black swan is actually a normal swan here. So I need to tell you, it's a white swan event in Australia, right? Well, you have white swan too. Anyway, so well, it only works somewhere else. So, but if we face rare events, then the AI may not work, right? But that changed the population, and also be changing behavior. So if the behavior, well, the worst example is the incentive for clinical practice changes, right? So another example on sepsis. This time is not about Epic. So during the past several years, there's one time that the CMS, which is kind of the national insurance medical care. So the CMS, Center for Medicare and Medicare, they change it. They elevate reimbursement for sepsis, and then the doctors, so they get more sepsis. So the doctors tend to give sepsis to, you're septic, because it pays much more, not a little more. And then the original AI did not sync with the doctors. I really like to joke about, there was one time that the CMS stopped paying for antidepressant for people with depression. Right? So they really get rid of the diagnosis called depression. So nobody used the diagnosis anymore, right? So everybody else will be mania, bipolar, I mean something else. It cannot be depression, right? So and in Taiwan, there's another example that the National Health Insurance stopped paying for antacid drugs. For the stomach, right? Because the antacid drug will just prescribe too much. And they stop paying for it. And then suddenly they eliminate a lot of peptic ulcers patient. Right? Because if you don't pay, we don't order, and we don't order, we don't put the diagnosis in there. Anyway, so the best way to eliminate a disease is to remove the treatment. Yeah. That's kind of, yeah, anyway. So that would be my last few slides. There are already some, of course, this is a big problem. So there are already some solutions from the NIH called Bridge to AI, and there's another initiative called Aim Ahead. Artificial intelligence, medical, machine learning consortium to advance health equity and researcher diversity. And then federated learning could change that, the bias, the sampling bias, selection bias, and standard evaluation and certification, which is still not there yet, unfortunately. So if you send to the FDA would just have to, go with whatever you're submitting. They cannot tell you, go to this third-party, evaluation center. Maybe you can create one here, and then then the FDA will say, yeah, since they signed it off, you could pass the FDA. And data transparency. So I've reviewed products that they say they got this hundreds of thousands of patients from Korea. But again, we cannot even see one image from Korea, and we don't understand Korean. So how do I, evaluate that this is right or wrong, this is good or bad? Unless they share at least partial of the data that they trained on and partial of the data they evaluate on. If it's a black box and they say, oh no, we spent so much money to get this, 10,000 images, I'm not going to share with you. Then how do we evaluate that this is workable or true or not, right? Once we approve in FDA, then everybody can use it, right? Then how do we know that it's okay? So it's really a tough call, okay? So anyway, I'll conclude with the AI plus big data could be really helping a lot, but still there are a lot of pitfalls ahead of us. But again, AI has to change the future of medicine because we deserve it. Thank you.